Thanks, Amya. It's always a pleasure to come back to the origin, and I really enjoyed all the talk. And I am thankful to the organizers for giving me an opportunity to speak on the tumor heterogeneity and theranostics of prostate cancer. So let us see what exactly is precision oncology. Why I have brought this definition is because many a times we use it interchangeably with theranostics and precision oncology. They are in many sense very much near to each other, but there is some basic differences also. So, in general, I would say the precision oncology is a field which has got its thrust from the development in the theranostics by, for example, defining the targetable drugs on the tumor and use the targets on those tumor and use those targets for the treatment. Let us say the example of this immune therapy. I mean, we all know that immune therapy has actually revolutionized the treatment of cancer cells. But if you look at the response rate, and you look at those patients who actually respond, it's not that all patients respond to that immune therapy. That 20 to 40% respond, and the rest may not respond to that. We really need to understand which of them actually responds and which do not. And it probably lies in the complexity of the carcinogenesis of because we all know that the cancer cells, by the time they manifest themselves in a macroscopic form or in CT or MRI, by that time there are a number of mutations which have actually taken places. And so carcinogenesis is a multi-year process. For example, we are speaking about the prostate cancer now. We have spoken also about the neuroendocrine tumor, but let's just concentrate on the prostate cancer. And you will see that there is already 20 to 30 years gone before the prostate cancers actually make themselves manifest in the processes, diagnostic tools, which we have. That means during this 20 to 30 years, they have developed a lot of mutational burdens, and they have developed the machineries to survive many different kinds of treatments which we offer to them, which we want to treat them with. What we also need to understand is when we use the treatments, cancer treatment, these cancer treatments are not always effective against all the different clones of cancer cells present within the tumor lesion. And that leads to a kind of a clonal selection. And because of this clonal selection, ultimately these tumor cells, the clones which are resistant to that particular kind of treatment, they become even more aggressive. It is very pertinent in the field of prostate cancer. I will show you why. But we have to remember this during the journey of the treatment of prostate cancer. First, this patient is a hormone sensitive, and then it moves into the hormone resistant or castrate resistant phase. And these different time period and the treatments which we offer during the 10-15 years of the journey of a patient through his prostate cancer, these treatment itself are producing some kind of a clonal selection, and they are pushing aggressiveness of these tumor cells. And we need to understand how we can assess and measure and take appropriate steps to prevent the aggressiveness of these tumor clones during a treatment. I have seen that this particular symposium is on theranostic within the lung cancer. So I thought that I'll show you an example of where we actually sometimes make a mistake by only concentrating on the classical DNM stage for the decision making of the treatment options available in lung cancer, for example, right? So this is lung cancer. I'll just show you this, some example. We actually did an analysis of 81 patients, all the stage 1 and stage 2 patients with no adjuvant chemotherapy. Curative tumor resection was performed in all cases. We had in all patients the pre-therapy FDG PET CTs, and we followed the patient for 4.6 years. And we did the texture analysis. We quantified the lesions, texture, CT, as well as PET texture. And then we tried to find out if there are additional parameters which can predict within this stage 1 and stage 2 operated patients, lung cancer patients, if there are additional prognostic parameters. So what we did observe was that within this stage 1 and stage 2, if we look at additional PET as well as CT and PET and CT combined parameters, for example, the PET solidity as well as PET SUV max and the CT volume, then these patients had a different overall survival depending upon which particular cutoff value you take over here. For example, CT volume greater than 1.4, these patients have a poor overall survival. For SUV max greater than 12.2, they have a poor survival. For solidity greater than 0.981, you have a poor survival. So that means within stage 1, stage 2, if you look at these image parameters, you can actually predict or look at the prognostic markers. And if you can inculcate these prognostic and predictive markers in your algorithm, there's a chance that you can improve the overall survival of these patients. So of course, size, number, and location may alone be misleading, and you have to consider the time factor. We also had a session on the neuroendocrine tumor. I think we all know that the PRRT is one of the most effective treatment options for the G1, G2, and probably in some of the G3 neuroendocrine tumors too. But sometimes the question comes up, as I mentioned, about the tumor selection during treatment. So previously, there were a lot of questions raised in the 2006-2012 period of my career that is PRRT leading to a clonal selection. For example, in this patient who was already treated with, it was a gastric net patient who was already treated with Y90 dotatate between January and March 2011 and showed an excellent response. Later on, the lesion started growing in the liver, and the question was raised whether this PRRT has led to the de-differentiation of the neuroendocrine tumor. So we have performed the MRI. MRI did not, at least this, you do have some parameters in MRI too, but in this liver-specific MRI, it was not possible to say which of the lesions are actually aggressive. So what we did the combined molecular profiling using the SSTR expression and the FDG metabolismus, and we found SSTR positive lesion remained stable, and rest of the lesions actually responded very well when we treated this patient further with lutetium dotatate. So it's a kind of a patient selection based upon molecular profiling, which we can do in the PET, and this helps in the proper treatment. And if you have certain patients where some of the lesions are somatostatin receptor negative, some of them are showing intense somatostatin receptor expression, and some on the PET are showing only marginally increased, peripherally increased somatostatin receptor expression, then these patients may actually may not benefit from lutetium PRRT alone, because you can induce a kind of a partial a kind of a clonal selection. This is the classical example of a tumor heterogeneity with respect to the targets present. So this shows that the targets which we are using for the treatment, they itself can vary in the intensity of the expression. So what we learned from the neuroendocrine tumor, before I move to the prostate cancer, is that what we learned from the neuroendocrine tumor is that the somatostatin receptor heterogeneity, the degree of expression of the somatostatin receptors on the lesions, can itself be a predictive as well as a prognostic marker. So let us see which particular scenarios can exist and manifest itself in the PSMA theranostics and the PSMA heterogeneity. We have spoken very proudly about all the different theranostic approaches which we nuclear medicine physicians have been the pioneer of, I would say, starting from the radioiodine therapy. But we still have to learn a lot when it comes to the interaction of the radiation, internal radionuclide therapy with the tumor microenvironment. We have been relying in majority of the cases, the experience from the external beam radiation therapy. Well and good, you can do that. And if you look only on the example from the external beam radiation therapy, you will probably learn that there is a very complex interaction between the radiation, the tumor cells, and its microenvironment. Some of the doses, radiation doses, leads to the upregulation of a certain non-prognostic or bad prognostic markers on the tumor cells, and some radiation dose actually leads to the killing of those and inducing sufficient double-strand DNA break. So radiation is not equal and does not lead to only one single kind of response. It can be both ways. And this was actually done and look at in a very beautiful study in the European Urology on the PSMA heterogeneity and their DNA repair defects in the prostate cancer based upon the H score. They found that those patients who have a higher heterogeneity of the PSMA expression, they have a poorer overall survival from this. So this was actually looked at the cellular level. So there is a PSMA heterogeneity. This concept has to be understood and taken into consideration for driving the theranostics of PSMA radioligands in prostate cancer. There's a huge heterogeneity available. And then this is another preclinical study which also looked at which investigated the PSMA radioligand therapy efficacy as a function of the cellular PSMA levels and intratumoral PSMA heterogeneity. So the study design is presented over here. This is a beautiful study which you all should read that. And what they did was they calculated, they looked at different kinds of tumors with different expressions of the PSMA expressions, different intensity of the PSMA expression of the tumor cells, and then they treated with lutetium PSMA 617, and then they resected the tumor and also calculated the tumor growth. After the resection, they looked at the lutetium uptake and DNA damage induced and measured by the 53BP1. And on the right, let's look at only the tumor volume growth. So if the PSMA expression is very intense, the tumor volume growth is less. If the PSMA expression is mild, as in seen in the green line, probably the PSMA expression is actually a prognostic marker for the tumor growth, tumor volume too in this preclinical study. And look at this 53BP1, which is marker of the double strand break in the DNA. So the higher the intensity of PSMA expression on the tumor cells, the higher is the DNA double strand break. So you see the heterogeneity of the PSMA has a significant role. Another important aspect which we all should understand when we are treating our patients and trying to interpret the PSMA expression on the tumor cells, that this PSMA might appear to be prostate specific, but it is not prostate specific. And some of the expressions of the PSMA, specifically, for example, in the primary tumor, can itself be influenced by the amount of folate present in and around in the microenvironment. So you see, PSMA is a metabolic enzyme, and the substrate can itself influence the expression of this PSMA. So this has to be kept in mind. Many of you might have read about it, but there is no clear-cut indication. For example, in the salivary glands, the uptake which you see, a very high intense uptake which you see, many say it's a PSMA expression. But if you look at the immunohistochemistry of the salivary glands, the the immunohistochemical staining will reveal that it's not very intense expression on the cell. So still we are seeing such high PSMA uptake. So where is it coming from? The heterogeneity of the PSMA expression is also significantly influenced by the region of the location of the metastasis. For example, we know that in a liver metastasis of the metastasized castrate-resistant prostate cancer patients, the PSMA expression can be extremely heterogeneous. Some of them may be intensely PSMA positive, some of them only marginally PSMA positive. And I always tell my residents to, and I have learned it over the years, that one must look at a diagnostic CT also and look at the hyperdense lesions, because sometimes it does help you in interpreting the aggressiveness of that prostate cancer metastasis in the liver. So restricting ourselves to the PSMA expression heterogeneity, this slide again shows that the PSMA expression heterogeneity varies depending upon the location of the metastasis. But the question is, how can we measure and how can we improve it? Just knowing something does not help our patients. We must be able to quantify it. We must be able to move from the objective assessment, from the subjective assessment to the objective assessment. And there are certain ways of doing a textual analysis quantification based upon the PSMA PET CTs and develop parameters like entropy, which is a marker for the heterogeneity. And then you can look at the response of those patients. And if these kinds of markers, heterogeneity texture analysis markers, are validated in a large set of patients, probably we will be able to treat our prostate cancer patients very well. Let us not forget that only 1/3 of the patients respond to the lutetium PSMA therapy with a very good response. 1/3 show a stable disease, and 1/3 of the patients, despite showing an extremely intense PSMA expression, do not go on to show any kind of response. So there's something going on behind in which we have not actually understood it. And one of the factors which we must remember in mind is the neuroendocrine differentiation of the prostate cancer, specifically in the stage of the disease where the patients come to us. Under the treatment, those hormonal therapies can lead to the neuroendocrine cellular differentiation. And under the neuroendocrine cellular differentiation, we know that the PSMA expression can be extremely faint, right? So this is something which we really need to look at it, e.g. again, by combining the or using the molecular profiling, using the two beautiful validated tracers, FTG and PSMA. For example, in this case, this was a poorly differentiated neuroendocrine carcinoma. The biopsy came from a small mass lesion in the pelvic region, which was hypervascularized on the peripheral region and centrally hyperdense necrotic lesion. And the biopsy showed that it is a aggressive tumor, as is shown with the Ki-67 80 to 90%. So the patient was referred to us, and we did the PSMA PET also. And what we observed that this aggressive mass lesion was only showing a peripheral increase in the PSMA, mild, extremely mild. Some of the lesions, lymph node lesions, as is seen in the para-aortic prevertebral lymph node lesions, some of them were showing PSMA expression, which was intense, and only faintly FTG uptake. So there was a tumor heterogeneity even in this neuroendocrine carcinoma aggressive patient. Not all neuroendocrine differentiated prostate cancer patients have no or faint PSMA expression. There are certain neuroendocrine tumor differentiated prostate cancer metastasis in liver, which can still have a very high somatostatin receptor expression. So just because a patient has a neuroendocrine differentiation of the prostate cancer does not mean that you say, okay, hands up, I cannot treat that patient. You must do the PSMA PET. For example, in this case, a classical case with heavily pre-treated with 9 docetaxel cycles, 28 cabazitaxel, and these are heavily pre-treatment cycles. And even then, The patient had a very good PSMA uptake on the metastatic lesions, and we treated him 4 times, and the patient responded beautifully. Thanks, Amya, for your effort. We could actually bring this paper also on the target heterogeneity. Some of the patients in this stage of the disease, metastatic castrate-resistant disease, as I mentioned, do show the neuroendocrine differentiation, and which can be very well assessed also by, for example, combining the somatostatin receptor PET-CT and PSMA PET-CT, and you can then offer these patients additional treatment. For example, combining lutetium dotatate or only with lutetium dotatate and lutetium PSMA. The approach of the use of the dual PET-CT for characterization of the heterogeneity of the PSMA expression by combining PSMA PET and FDG has also been done in Australia several number of times, and we now have data to show that it also has an influence on the overall survival, right? So it does help. Where are we moving in the future? In the future, we will have to understand the basic structure of a cancerous lesions. We will have to develop a new peptides which higher affinity and higher circulation time to overcome some of the resistance of the prostate cancer, despite showing PSMA expression. For example, in this case, we used this lutetium PSMA 201, only 500 megabecquerel, and the patient actually responded, although this was a dosimetry dose, but the patient still showed a beautiful PSMA response. The other way to overcome is, of course, by understanding the DNA damage repair and the genes which are responsible for the radioresistance and radioprotection. And of course, by switching over from the lutetium-177 to alpha therapy, because alpha induces higher DNA damage, double-strand DNA damage as compared to lutetium. So in those patients who are not responding to lutetium, still in those patients, the alpha PSMA works very well. So if we understand our mechanism of DNA resistance, of the radio resistance, then we'll be able to treat our patients much better. For example, we did hear about the olaparib combination. We have been doing at university on some of the patients we have treated in combination with lutetium PSMA. Those patients who are showing DNA damage repair genes, you can combine them together, lutetium PSMA and olaparib, and achieve a good and durable response. We are also doing how to move forward. That is a topic future. So we are also actually doing a liver biopsy or biopsy from the lesions to see if those patients are actually showing some kind of genetic mutations and find out the targetable drugs. And this should be done in patients who are having PSMA heterogeneity. We can also look at the germline gene variants and see if there is any kind of correlation with the response. For example, we did it. This was a study from the Bad Berka group from Richard Baum, and in this patient subgroup, heavy selected patient subgroup, we can identify check to germline mutations as one of the probable good prognostic markers, under which the patients can respond beautifully to the lutetium PSMA. So this is the future. In some of the cases where the tumor heterogeneity is very, this PSMA heterogeneity is very intense, you can actually think about offering those patients, for example, CAR T cell therapy with PSMA targets, and we have treated a couple of patients, with one patient showing good response. The future is, again, as I've mentioned many a times, a combination of different approaches, different methods to characterize our patients well, and use this territorial management aspects for the treatment guide, which I think will be the future. The future cancer treatment will be performed directed by the cancer's lesions profiling and not based upon only on the primary tumor. So to conclude, heterogeneity of target expression has a deciding role in the efficacy of all radioligand therapies, specifically in prostate cancer. Watchful approach towards PSMA RLT is warranted. High response alone is not a guarantee for improving OS because of the heterogeneity of PSMA, and that is why we need to think about sequencing and combination, and also we need to understand much more about PET CT and PET-RMI images to understand the PSM heterogeneity and guide our patients' treatment much better. With that, I would like to conclude and thank you for the opportunity to speak.
Thank you, Dr. Vikas. Wonderful talk as always, and you have highlighted different aspects of heterogeneity in a very elaborate way. We have no particular questions, but one question from my side regarding the role of using FDG PET in planning therapy for prostate cancer. So, do you use a particular Gleason's cutoff beyond which you decide that now we are going to do FDG PET before going ahead with PSMA RLT, or there are any other biomarkers which you use in order to deciding whether FDG PET should be done for a particular patient?
Mm-hmm. Thanks, Simon. This is a very important point. So there is no particular cutoff per se which I can recommend as of yet. The study is going on. I have been doing FDG PET only rarely in my clinical practice. I'm relying more upon a PSMA PET CT, good diagnostic CT, and looking at the clinical parameters to come to a decision. But if centers want to do that, they should be looking at the cutoff value for the FDG because it has not been validated as of yet.
Thank you very much.